One of the innovations in terms of global health was the decision back in 1960s about recruiting operations officers as well as medical officers. And some of the African countries were kind of upset that we're sending people other than doctors. After a few years, they only requested operation officers. They wouldn't, because they were the practical people, the thing that's going. And I would have to, Don mentioned Andy Eagle. I did Andy's recruitment, and it took 45 seconds. He came in, he said, I saw this CDC announcement. They needed a public health advisor who spoke French and was a good mechanic, and I know you needed me. One of those operation officers who has stayed with disease control activities around the world is Dave Newberry, and Dave is going to talk to us now about the polio program. As I always, when I introduce David in my class, I always say, this guy shoots geese.
And Stan eats them. It's a pleasure and an honor to be here, being probably the most least qualified people to speak on this topic. I was intrigued at security this morning. They let me bring this little penknife through. And I think probably the rationale for that was that I could probably only hurt a bunch of old people if I took it out. But it is humbling to be here, and most of you in this room have taught me what little I know about disease control and containment and the hard work that the field requires in order to achieve goals. And I want to acknowledge at the outset that eradication of any disease or control of any disease in any country is a work of indigenous people, people that live there, work there, are in the trenches. Those are the folks that deserve the credit. We can pat ourselves on the back till we require shoulder surgery. So many of you have helped me learn what I know and have given me the opportunity to serve in that capacity that it is humbling. My special appreciation goes to Dr. Fagey, Dr. Hopkins, Dr. David J. Sensor, Dr. Jim Chin, and Stan Foster. Also would like to acknowledge my appreciation to God for giving me the opportunity, and Bill Wilson and his friends for opening my life up to that capacity. Yesterday, Dr. Thacker mentioned polio eradication twice in the history of CDC. And Don Millard this morning mentioned the fact that, that we don't give up the battle. It is a war. And if you think that if we give up polio eradication now, we're going to be able to control it, I want to tell you you're mistaken. How many times have you gone to a village and you can see the susceptible cycle and the movement of virus in that village? You see 9 and 10-year-old kids crawling like crabs on the floor, on the ground. Then you look and you see young adults, 19 and 20, crawling like crabs on the ground. And you know that the susceptible cycle and movement of virus, polio virus in that community is about 10 years. That's not rocket science. I'd like to start this to talk to you about how I'll present this. Rudyard Kipling, in his Just So stories, made this statement, and I quote, "I keep 6 honest serving men. They taught me all I know, all I knew. Their names are what and why and when and how and where and who." So we'll look a little bit at this. I'll specify why, and I'm embarrassed to do that because each of you know a lot more about the epidemiology of this subject than I do. I'll describe how, in terms of strategic components, we're going to address this. I'll identify who are the key players. I will address, not in full, but some of where the geographic problems are, discuss the what by current status, and then also by the challenges, and finally to defend and define when in regards to polio eradication. Okay, the host. The host is a simple disease triad. We know that the the epidemiology of any disease is based on the host, the means of transmission, and the agent. Now, we can't eliminate the agent. We can't eliminate the host because that would be cruel and unfair. But we can deal with protecting the host. And the means of transmission, of course, is based on poor personal and environmental hygiene. The means of transmission, of course, is oral fecal, and we have a problem because there's rapid spread through inapparent cases. The virus is excreted intermittently for 4 weeks or more, and of course it can also be carried by adults or children. And protection is thought to be lifelong, naturally acquired by infection or through OPV vaccine, through the Savin vaccine. But we are also challenged to try to meet a coverage of 90% or greater. The how covers the strategic components, and we really are. We must look at. We could just summarize this whole thing and say surveillance, 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 and appropriate response. Thank you, Stan. But we're not doing that because right now we're at a critical element and component and stage where there are a lot of naysayers in the world saying it can't be done, and I think that's a tremendous challenge for us to think better and to provide a higher focus on what we're going to do and how we're going to do it, how we're going to meet these challenges that come up. So we focus on the high-risk areas, hard to reach, low coverage, and where wild polio virus is being transmitted. Now, the oral polio vaccine is our major tool in terms of protecting the individual. The predominant strain in the world is P1. But we do know that there are 3 subtypes, P1, P2, and P3. Now, we've eliminated P2, and P3 is on the run. The predominant strain in the world is only P1. And we've also developed the approach. Most of us thought when Ciro de Quadros was saying that we can do national campaigns and eliminate polio, I think most of us thought, well, you know, maybe he's had just maybe one too many cerveza. But he was right. He's correct, I believe. Mass campaigns do work. And I also want to emphasize that I work in a PVO community that's funded to the tune of $25 million, and we have about 40 partners that are national, international PVOs, but on the country level we have hundreds of partner PVOs. And we are working where it's important to be. So I think that that's one thing that we have to bring. We have trained tens of thousands of volunteers working at the community level, and we'll talk about that a little bit more. We also have extremely active surveillance activities in place. Now the revised target for acute flaccid paralysis is 2 per 100,000 kids less than 15. This gives us our sensitivity issue. We can deal now more correctly with identifying paralyzing kids, and then we take the specimens and we can track our progress or lack of. We have very sophisticated, one of the legacies, we left very little legacy from smallpox, perhaps expanded program of immunization. For polio, the legacy we're going to leave is going to be sophisticated laboratory poliovirus capacity. It is incredible what has changed in that respect. We do have the capacity to identify the organism and start mop-up within 3 days. And I think and this is appropriate. And the genotyping, I think, is really complex and really interesting because we have to have that mechanism in order to track when we're eliminating strains, and we can tell when a case goes to a company where it came from and where its grandma and grandpa is. Okay, the where targets high-risk areas, and I won't go into all of these. We do know that India, Afghanistan, Pakistan, and Nigeria are countries of interest because of endemic transmission. There are a lot of countries that are at risk because of importation potential. Some of these are bordering countries, and we know that Nigeria is sort of a nightmare for that. And we have to contain all importations, and we have to do that in a timely fashion that restricts any kind of mass problem or outbreak. Well, what covers the status? Well, we have greater PVO and community involvement now. And one of the problems with CDC and WHO is you're not connected to communities. We PVOs, we work and live in the communities, and we work and live in communities that are where there's poor infrastructure or where there's no infrastructure. So we are an important tool in this area of a disease that is epidemic and pandemic where there is no infrastructure. And these situations go on unnoticed. We have better community focus. We have door-to-door and multiple team visits. And if in India, I don't think that we've overcome resistance so much as we just wore it out. You know, when the fourth team knocks on your door and says, immunize your children, you finally say, okay, quit bothering me, do it. And we have very, very good social mobilization efforts going. It tells people why their children need to be, why they need to be immunized 14 times if that's the 14th NID. And these are kind of complicated behavioral aspects that we come to deal with sort of on a one-on-one basis when you go door to door and house to house. We also have trained, we have a lot of good training that keeps improving for volunteers, and as I mentioned, there are hundreds of thousands of those now. And we have supportive supervisors. Thank you, Stan, again. We have a community, we deal with sanitation and hygiene. Now, we PVOs can do that on a little better basis because we're not going to go in and put in new water and new toilet systems. But we do apprise people, and we do have projects going in which the community does focus on the need to clean up their area and the danger of having a contaminated environment. And that's an inducement as well. We have the capacity to reach these areas that don't have infrastructure. We also use multiple interventions, including measles immunization and deworming and actual health fairs, which if you go back to a community for the 10th time and you show up with something else, it helps a little bit. And it finds that there's a lot more interest in what you're doing when you're able to do that. We also use we want to strengthen routine immunization, and we use reach every district approach, and which means we now have to move this to giving OPV at birth. We're not, because you take it like UP, there are 20,000 newborns every day of every year. And we look at the move of the polio virus, it attacks the younger and the younger cohort, and that's because we're not getting those kids. And so that's the focus that we're doing. Now, the big challenge is, what about funding? It takes about $700 million a year to cover this project. I think it's a bogus, and I'll talk about that a little bit. The what covers some of the challenges. Feasibility, can it be done? Well, every time a challenge has come up, we've met new tools. I was talking to the Bangladesh folks this morning. They said there's 7 cases of polio in Bangladesh. And I said, great, that's wonderful. Now we can get out there and we've identified these cases with a surveillance system that never existed this well tuned before. Now let's go out there and contain this outbreak, and I only want to see 7 cases. I mean, that's the approach. Every new problem has provided us with some new tool to meet that challenge. Coverage, well, the focus has to be where the wild polio virus, the enemy, exists. And it's taken a long time in places like India and other places not to take sort of a generalized approach. We really have to use the epidemiologic information that's available, and there's an incredible amount of information in NPSP, the Nigerian Polio Surveillance Program. It's unbelievable at the rich data that's available to make decisions and to activate people to fight the virus. Now, the other thing is, of course, we know that wild polio virus can be seeded globally through adults and children, and we know that this from our Hodge experience in Nigeria. We had a proliferation and an explosion, if you will, previously polio-free countries being infected through Hodge and that gathering there. Now, there's also the naysayers say, well, countries of conflict can't be dealt with. Well, when I went to Angola had a 27-year civil war going on. I met the Minister of Health and the Vice Minister of Health, and I said, look, this is an opportunity for us because in the IDP camps of Luanda, we had about 12 to 1,500 cases with 200 deaths. Do you realize in that context that we have more than 250,000 children protected in order to have that number of cases? And I said, the other thing that works in our favor, we have control and we can immunize the metropolitan areas. We can't the rural areas because the UNITA holds the rural areas. So all we have to do is do our job in these populated areas, and then we can eradicate polio from Angola. And we did in about 2.5, 3 years. No one's got an excuse if we could do it there in terms of conflict. I do think, and it's been mentioned before, that we have to focus more on a cultural, ethnic, and religious sensitivity of the populations we're dealing with. We have to create partnerships with these folks on a basis that commits them as well. The WHO, well, the key players are, of course, country-level polio eradication field workers, thousands of trained community volunteers, house-to-house, technical agencies, CDC, WHO, UNICEF, and the donors are USAID, Rotary, and of course, Rotary will probably get the great prize for it. Okay, I've got 1 minute, so is it time to give up? Well, I don't think so. All our surveillance and our lab backup, our ability to collect specimens within 2 weeks, and to get a response set in place. I think we got to focus on the new birth cohort. Nigeria's failure taught us the real enemy is polio, wild polio virus, not keeping people honest or any other side activity. Countries are dangerous to work in. Nepal, we've done it. We have a PVO community has immunized 25% of all the children immunized in Nepal, and we continue to keep that border covered, knowing that the virus can come in from India. Well, it's true. We have serious obstacles, but we've reduced polio morbidity by about 99%, and we can't give up now. Time target goals are the biggest enemy we have. There is absolutely no rational reason why we should continue to say, well, we missed 2000, let's go to 2005, let's go to 2007, let's go to 2009. Let's forget about it. Let's just get the job done. Now, $700 million a year is too costly. Do you realize that in the U.S., $4 billion every year are donated to animal charities, just animal charities? And you realize that in the U.S. we are also guilty of spending about, as of 2000, about spending $28 billion per year on our little furry creatures. Okay, so there's an African proverb, when elephants fight, it's the grass that suffers. And you notice in the middle picture, the grass includes people and households, and so the elephants are the naysayers, and those are the doers that are trying to overcome this disease. So finally, I want to say the when will be when the last case of polio has run its course through the individual infected. And I say that the motto we must adopt today is now, more than ever, let's stop polio forever. And no target date is needed. Thank you.